My name is Dr. Musha. I am the retinal surgeon. So I deal with a lot of nerve issues. Good morning, everyone. Morning, good morning, guys. Okay. If you can't hear me at any point, if you don't understand, please stop me. Okay. So this is the first time I'm giving this lecture online. Right. So feel free to stop if you don't understand at any point. Okay. Okay, now we are going to talk about the ocular manifestation of systemic diseases. What it means is basically is you have this medical, underlying medical problem, but then you can see some symptoms and signs in the eye. Now, there's a lot of systemic diseases that can manifest in the eye, but the one that you have to concentrate, at least at your level, is diabetes mellitus. That one you already have a lecture, right? Dah ada kan? Okay, hypertension is another one. Thyroid eye disease, myasthenia gravis, a bit on as rheumatoid arthritis, and we will go through some of the a bit more less frequent, which is AIDS and also the uveitis cases. Those are the systemic diseases that you have to know. Yeah, there's a lot when you read your textbook banyak, so you don't have to read every single thing in the textbook. Concentrate on the common diseases. Okay, we will go for hypertensive retinopathy. Hypertensive retinopathy. Now, as a start, I would just like to mention that everybody learns the layer of the retina. We have 10 layers of the retina, right? So the retina should be a very dry area. In other words, the blood vessels are very tight. The junctions are very tight. So there should not be any leakages of fluid, blood, or whatsoever. As compared to your choroid, it has a lot of fenestration. Yeah. So and in that choroidal area, it's actually very wet. So what actually keeps your retina dry is because of the tight junction, number one. We call it blood ocular barrier. And there's another barrier, which is your RPE, your retinal pigmentary epithelial layer. So those two layers intact, then you get a very dry retina because your choroid are very much porous and very wet, yeah, because it's very fenestrated. So those are the main changes or main differences between the retina and the choroid. Now, basically what happens when the patient has hypertension, there will be damage on the wall, mainly because of the high arterial pressure, and increases the TPR at the same time. Yeah. So what happened now? Let me recap the anatomy of the eye. I hope everyone remember that when it comes to anatomy of the eye, some parts are avascular. Avascular means there's no blood vessel. Yeah. Which part is avascular? Which is the cornea and also the sclera. So these two bit, the coating of the eye does not have any direct blood supply. All right. So where are the blood supply? Mainly at the choroidal layer, this red area ni, and also at the retinal layer. Okay, so you have avascular region and also vascularized region. So the vascular region is the one is going to be affected by your hypertensive changes, obviously. Yeah, the one yang tak ada blood vessel, your cornea, your sclera will not be affected by your hypertension. All right. So because of that, hypertensive changes in the eye, you can divide it into damage on the retina, causing retinopathy, damage on the choroid, causing choroidopathy, or even the optic nerve, optic neuropathy. So optic nerve pun ada dia punya own blood supply. Yeah. So those are where the problem occurs. Now, what happens when you have a high blood pressure? This applies to all other system as well. So you get a generalized vasoconstriction of the blood vessel, the artery. You have thickening of the blood vessel because they try to accommodate to the rise of high pressure, and there will be eventually arteriosclerosis. Yeah. So when the blood vessel of the retina, which is supposed to be very tight, should not leak anything, eventually it will cause leakage when the blood vessel wall is damaged. Now, another thing that can happen as well is when there is changes of the blood vessel wall, it can also cause changes in the flow of the blood. So it also can cause some what we call a microinfarct. So you get a cotton wool spot at the retinal layer. So remember your 10 layers of the retina, your blood vessel lies on the surface, on the nerve fiber layer. Yeah. So all hypertensive changes mainly occurs at that nerve fiber layer region. All right. So Now, as you can see here, what's this? A cotton wool spot, right? Try to look at the ages. What is important for you to see is, one is the color, number two is the ages of the lesion. Now you can see dia macam brush fire punya edges, nampak tak? Dia macam feathery edges dekat ujung tu kan. So those tells you that this lesion is sitting in the nerve fiber layer. Okay, diabetic is different. Diabetic occurs in a deeper layer, small blood vessel. Hypertension changes occurs in a superficial layer of your retina. Diabetic changes occurs at the outer plexiform, very deep layer. Okay, so when you see diabetic patient, you don't see cotton wool spot, right? You see a lot of dark blot. You don't see cotton wool spot because cotton wool spot is the micro infarct of the nerve fiber layer. Now, what else you should see? You should see hemorrhage. Now, remember with diabetic, you get dot or blot. There's no, it's like just an ink blot kind of hemorrhage, right? But for hypertension, particularly, it is a flame shape hemorrhage. So cotton wool spot actually is the same shape as the flame shape. It's just the color is different because they are in the same layer. Okay, so how it appears looks more the same. The edge of the flame shape nampak macam brush fire ataupun nampak very feathery. So you know this is a hypertensive changes because it's in the fiber layer. The color of the cotton wool spot is supposed to be white. Now, why I mentioned that? Because another changes that you have to look for is the exudation, hard exudate. So remember, you get a micro infarct, you get a cotton wool spot and hemorrhages. But if let's say it leaks out, you get exudation. Yeah, lipid exudation. So lipid exudation, usually the color is a bit yellowish, and it's usually very quite deep inside. Hard exudate is not common in hypertension compared to diabetic. Diabetic, you get a lot of dark blood exudation, a lot more than the hypertensive changes. Yeah, so those are the main difference between the two. Now, whatever you see in the retina, now in your body, the only place that you can really see blood vessel is in the eye. So that is why you should be able to sort of differentiate whether this is hypertensive patient, vein occlusion cases, or diabetic cases. Those are the common ones that you have to know. Yeah, vein occlusion, diabetic, hypertension. Yeah, so whatever changes that you see mainly depends on the chronicity of the disease, the age of the patient, and you can have this acute rise of high blood pressure that represents the severity of the high blood pressure. Yeah, usually for the young ones. Now let's look into the how does a normal arterial to venous ratio looks like. Okay, which one is the artery? The darker one. Okay, now this is the artery. This picture is not superbly nice, but this is a photo. But anyway, the smaller one should be the artery. The bigger one, the darker one should be the vein. So the artery should be smaller than the vein. Okay, can you see this? The artery is sitting on top of the vein. Most of the time, artery crosses over the vein. All right, that is in the retina. This is very important for hypertension. Yeah, the position of the artery in relation to the vein is important for your hypertensive changes. So normal eye ratio should be 2 to 3. Now, when you have all the damage of the blood vessel will be narrowing. The moment you get narrowing, you get hardening of the blood vessel, you start to see copper wiring and silver wiring. Copper wiring, silver wiring susah nak differentiate, but at least at your level, dapat diagnose silver wiring pun dah cukup. Yeah, you don't really have to differentiate, oh, this is copper, this is silver. Usually it starts with copper first, and after that it goes to silver. Yeah. Why do you get the silver wiring? Sebenarnya the blood vessel itself is not white, but because the reflection of light that you get from your fundoscopy ophthalmoscope, yeah, that you get that reflection at the tip of the blood vessel. Now again, you can see the artery is actually crossing over the vein, right? So you get vessel narrowing, AV ratio will be much reduced, so 1 to 3. So the moment you get this kind of changes in a patient, in all quadrant, easily you can diagnose patient to have hypertension. Okay, chronic hypertension, not the acute one. Yeah. Now let's look at the classification. When you go to classification, there's a lot of classification. So this one is actually not sure. I use the Keith Wagner Barker. This is the most common, the oldest one, but I think for your level, this should be enough. Yeah, there are a few other new classification, but that is a bit more complex. So let's just concentrate on this. So how do you remember the grading? We have grade 1 to grade 4. Remember the keywords. So for grade 1, basically what you're going to see is the silver wiring. So the moment you see silver wiring, look at the patient has grade 1 hypertensive changes. Okay. Now, remember artery goes over the vein. So arteries becomes harder. Once artery becomes harder, much heavier, it compresses on the soft vein. Vein is always soft, non-bulk, kan? So they akan compress on the vein, underlying vein. The more thicker the artery, the more compressed the vein would be. So what happens is it will cause what we call a tapering of the vein. So that is when you get AV nipping. All right, that nipping, the nip. Okay, it's nipping, not napping. It's nipping. Salah hija tu. Yeah. So grade 1 you nampak silver wiring. Grade 2, the moment you see AV nipping, you know it's a grade 2 hypertension. Just look for all those important signs. Yeah. The moment you nampak hemorrhage, you tahu it's already grade 3. Okay. Usually it comes with quarter wool spot and also heart exudate. Selalunya it comes together. Bila ada flame shaped hemorrhage, it comes with quarter wool spot. Now there's something important about this grade 3. Grade 1 and 2 usually tells you a chronicity of the disease. Yeah. But the moment you get flame shaped hemorrhages yang banyak ataupun quarter wool spot yang banyak, you know, it's not only the patient has chronic hypertension, but the patient has uncontrolled hypertension. Okay, so the moment you do fundoscopy, nampak, oh, there's a lot of quarter wool spot. Dia tahu, ni mesti tak control pakcik ni. Alright, so that will give you a clue that the blood pressure is not well controlled. Once you control the blood pressure, the quarter wool spot will immediately disappear. Yeah, it can disappear. But flame shaped hemorrhages probably is a bit difficult, but these hemorrhages can come and go. Alright, but the one that is going to stay is usually your silver wiring and also your AV nipping. Now, if let's say patient comes with a sudden rise of high blood pressure, either newly diagnosed young patient ataupun dia tak pakai ubat for a few days. So when patient has acute rise of blood pressure, they will end up with all those changes. Semua ni memang ada, akan ada, plus optic disc swelling. Alright, so this optic disc swelling will cause, it is a grade 4 hypertensive changes. Now remember with hypertension, the changes should be bilateral. Dia tak boleh sebelah mata. And it's not sectoral. Okay, kalau ada 4 branches of your artery and vein dalam retina, it has to be in all 4 quadrants. Kalau you nampak sectoral, then it's not hypertensive retinopathy. It has to be something else. Okay, so it has to be bilateral, it has to be generalized. Now, let's go for the next one. Now, this is just to show you how, okay, normal condition, size looks normal, looks nice, artery over vein. Then slowly you can see the thinning of the compressed vein. Slowly it becomes tortuous and deviated and eventually become your AV nipping. Yeah, so that is how it will appear. Now let's look back at this patient. The right eye ke left eye ni? It's the right eye, yeah. So this is the right eye of a patient. Optic disc is on the right side, so this is a right eye. This is your macula, kan? So this is your artery crossing the vein. This is supratemporal artery, infratemporal artery. Sorry, infranasal and supranasal. This is a nasal region. This is your temporal region. Yeah, so macula is at the temporal region. Okay, so obviously this is a patient fairly quite old. You can see the silver wiring. In normal eye, you should not see anything reflecting so bright from the artery. Yeah, so you can see this is, as you can see, this is grade 1 hypertensive changes. Remember, usually grade 1 vision is good or bad? It is usually good. Okay, in other words, your optic nerve function is going to be also perfectly good. So patient should not complain any visual symptoms. Okay, now grade 2 hypertensive changes, remember what do they have? They have AV nipping. Nampak tak AV nipping? Okay, when you want to look for AV nipping, you tak payah cari jauh-jauh. Usually it will happen here. First branch and the second branch. Usually is there. Yeah. So what you have to, if you want to look for AV nipping, you look for the vessel around the disc. Usually location is that. Usually tak ada dekat tepi-tepi ujung-ujung. Usually it's just around this corner. Yeah. So this is what we call AV nipping. You can see this is the artery that branches out from the main artery. It is at the second branch. Nampak tak? Okay. This is the first branch. And this is the second branch. Usually AV nipping is at the second branch. Yeah. So this is a AV nipping 1, AV nipping 2. right? On top of that, they also have silver wiring. So this is at least grade 2 hypertensive changes. What about the vision? Vision will always be good still. Yeah. Optic nerve function is also good. Now, let's look at grade 3 hypertension. Again, remember just now the moment you nampak quarter spot, you nampak flame-shaped hemorrhages. Again, usually all these things will happen around the optic disc. So by right with your direct ophthalmoscope, boleh nampak ke? Tak boleh nampak. You should be able to see. Remember your ophthalmoscope magnification is almost 15 times, 1.5. Yeah. So all these hemorrhages should be quite apparent on your ophthalmoscopy. So should not be that difficult. Okay. So how will we describe this? This is the left eye. Now there is obviously hemorrhages in all quadrant, betul? Doesn't spare any quadrant. Semua ada. Nasal ada, temporal ada. Then you have quarter spot, all quadrant as well. And your heart exudate. Now vision depends. Kalau heart exudate dia banyak, vision will be poor. Kalau heart exudate macam yang ni, obviously vision is going to be affected. Okay, good vision means kalau dia baca Snellen is 6.6, betul? You ada tengok Snellen chart. Snellen chart kan kalau you pergi kedai cermin mata, right? On the top is 660. Bottom is 6.6. 6.6 means perfect vision. So in patient with hypertensive retinopathy, kalau dia ada heart exudate like this, probably they will go halfway. Alright? Tapi kalau let's say heart exudate dia is not at the macula, vision will be perfectly good. Faham? Boleh? Okay, okay, good. Optic nerve function generally will be still good. We will go to optic nerve function later. Yeah, tapi just remember, vision usually is good unless ada heart exudate dekat macula. Optic nerve function is also usually is good. Okay, let's see. Now, dah nampak heart exudate, you already see the flame-shaped hemorrhage, tiba-tiba you nampak optic disc swelling. So you know this is already grade 4. Grade 4 hypertension does not really tell you about the chronicity, but more of the acute rise of blood pressure, because in other words, the optic disc swelling will resolve once your blood pressure comes down. Yeah, usually it can go up to diastolic pressure of 180. The systolic pressure 180 and above. You will start to see all these things. Acute rise. Yeah, especially the young people. Now, vision again slightly affected because depends not because the optic disc swelling. Vision is affected because of the heart exudate. Okay, bear in mind in hypertensive retinopathy, the optic nerve function is always normal. You have to remember that. Yes, sebab there are situations whereby you have to know about optic disc swelling. Kan? Ada optic disc swelling, optic nerve function dia abnormal. What is the diagnosis? So there's a different diagnosis. Tapi kalau you dapat optic disc swelling, optic nerve function dia good. So your differential diagnosis is also different. Yeah, so kalau you buat fundoscopy nampak optic disc swelling, but yet the vision not so bad, RAPD negative, visual field pun more or less normal, tak ada visual field defect, tak ada red desaturation, then think of grade 4 hypertensive retinopathy, and it has to be bilateral. Remember, both eyes. Dia tak boleh sebelah. It has to be both eyes. Yeah. Now, tadi dia ada, remember blood vessel you ada di choroid. Sorry, your blood vessel is in the retina, and also there's a lot more in the choroid. Yeah. Choroidal blood vessel is much more leaking. It always leak all the time. Yeah, it's always wet at that particular area because a lot of blood vessels there. So they can also get hypertensive choroidopathy. Now, hypertensive choroidopathy is not chronic hypertensive changes. It doesn't go. Nampak tak your grade hypertensive grade grading does not include choroidopathy inside there. Yeah, because hypertensive retinopathy mainly talks about chronic disease. But when you get acute rise of blood pressure, you get choroidopathy at the same time. Okay. How will they present? Usually you will see this kind of patient, young patient. Patient usually comes from the OAG side. Patient pre-eclampsia, yeah. Sudden rise of blood pressure, they will complain they have a poor vision. When you go and see, usually what you see is they will see exudative. This is very common. Exudative retinal detachment. You can see detachment of the retina in a young patient for no good reason, okay? And then you check the blood pressure is high. So what happened? How do we treat this patient? We just need to control the blood pressure. Once you control the blood pressure, all the exudative detachment will resolve. So at least for your level, you should be able to diagnose exudative retinal detachment. Choroidal infarct is a bit difficult for with your fundoscopy, but at least you know the facts that what happened is sudden rise of pressure, occlusion, choroidal will be infarcted, macam your cortical spot infarction just now kan, choroidal infarcted, but then because the infarction of choroid merosakkan the RPE layer. Remember your RPE? RPE should be a very tight junction yang what does RPE do? It is a barrier, right? Kan? It's a barrier whereby it keeps the wet choroid area not to spill into the retina layer. So they keep the retina dry. So bila there's a infarct in the choroid, it will also affect your RPE. Once RPE pun infarct, all the fluid from the choroid will go into the retinal space. So that's how you end up with exudative retinal detachment. Yeah. If you look at the blood supply of the retina, kan retina ada 10 layers. The superficial layer is being supplied by the retinal artery. The photoreceptors downward supplied by the choroidal circulation. Yeah, so when you have a damage on the RP or choroid, you get the exudative retinal detachment. This is the example of exudative retinal detachment. Boleh nampak tak ni? This is your optic disc. This is your blood vessel. This is the retina. You can see the retina is actually ballooned up forward coming to you. Yeah. So this is where you see the retina is elevated. Okay. In this situation, you don't do surgery. Remember your retinal detachment, there are three types of retinal detachment. Satu is the exudative type, which is this one. There's no tear. There should not be any bleeding. All right. Vision is definitely going to drop as well because retina is detached. Number two, the other type of retinal detachment is your rhegmatogenous. Rhegmatogenous, pandai tak Ija? RHEG. So that is in your acute vision loss punya lecture. Yeah. So rhegmatogenous means ada koyak. So there's actually tear on the retina causes retinal detachment. In that particular case, patient needs surgery. All right. Okay, there's another type of detachment is what we call a traction retinal detachment. Traction retinal detachment is when mainly for diabetic patient. Yeah. For proliferative diabetic retinopathy. So for systemic disease, diabetic can also cause retinal detachment, which is a tractional retinal detachment. Yeah. How to solve that problem? Treatment-wise is only surgery. In tractional detachment, you don't have tear. Okay, there's no tear. And hypertensive detachment, you don't have a tear as well. Tapi what you need to do, you don't need a surgery. Yeah, just to control the blood pressure. Okay, now how do we manage them? Kita refer patient to the physician. Admit the patient if the BP is not well controlled, and everything will resolve. Do we follow up this patient? Remember, your diabetic patient needs a very frequent follow-up, kan? A minimum of yearly follow-up of hypertensive changes. We don't usually follow up them, all right? Unless they have visual complaint, all right? So, patient akan complain. They will actually complain once they reach stage 4, but not at stage 1 or 2. Remember, we don't give them any lasers. Okay, now this is not part of hypertensive retinopathy, but when the patient has hypertension, they are at risk of developing vein occlusion. All right, so you have central retinal vein occlusion, which involve all 4 quadrants. You have branch vein occlusion, you have artery occlusion, branch and central. Yeah. Another one, I think this one also you need to know, anterior ischemic optic neuropathy. I think this one will cover in your acute visual loss. It is related. And sometimes students are easily confused whether this is a CRVO or is it a hypertensive retinopathy? Or is this diabetic retinopathy? Yeah. So now, why can't this be hypertensive retinopathy? Let us describe. This is your left eye. Yeah. Okay, remember your hypertensive retinopathy have flame-shaped hemorrhages. Yeah, this is flame-shaped hemorrhages, but in all 4 quadrants, right? Sama, hypertensive retinopathy pun ada flame-shaped hemorrhages in all 4 quadrants. But why can't this be hypertensive retinopathy? Remember that we discussed just now, hypertensive retinopathy will have a lot more hemorrhages around the optic disc. Yeah, not so much at the periphery, usually. This one is a full blown, nampak tak? In all quadrant up to the periphery. Okay, not only that, they have the flame-shaped hemorrhages, but also they have a lot of this blood hemorrhages. Okay, in hypertensive retinopathy, you don't get so much of blood hemorrhages. Yeah, so when you have a mixture of so much of blood and flame-shaped hemorrhages, this is what we call central retinal vein occlusion. Okay, can it be a diabetic retinopathy? No, because so much of flame-shaped hemorrhages. Diabetic retinopathy usually there's a lot of dot blood hemorrhages. Okay, the shape of hemorrhages will determine what kind of disease you're dealing with because the management is different. Yeah. Now, again, this one. This is the right eye of the patient. You can see optic disc swelling. You don't see the margin very well. You see flame-shaped hemorrhages. Very nice. But why can't this be hypertensive retinopathy? Because it is sectoral, right? This area is completely clear. Remember, hypertensive retinopathy has to be generalized and also in both eyes. It cannot be sectoral. So when things are sectoral, think of your vein occlusion. Vein occlusion or artery occlusion is common to be sectoral. Diabetic retinopathy, no as well, because diabetic retinopathy has to be in all four quadrants. Dia tak boleh just sectoral. Okay, so how you describe this? You get optic disc swelling, you get flame-shaped hemorrhages, tortuous vessel. Really the vein, nampak tak? The vein is actually very tortuous. You nampak tak this one? This one is the blood hemorrhages, heart exudate. So if you get a OSCE question describing, okay, tell me 5 abnormality in this picture. So start number 1, optic disc swelling. Number 2, flame-shaped hemorrhages. Number 3, your dot blood hemorrhages. Number 4, tortuous vessel. Number 5, your heart exudate. What else? Absence of foveal reflex. The moment you get absence of foveal reflex, maksudnya the macula is swelling. Now, nampak tak ni? Can you see this? A fan-shaped looking blood vessel. What is this? This is your new vessel. So this is hemi-vein occlusion which come with all these features. Hypertensive retinopathy do not have new vessels. Okay, boleh tak hypertensive retinopathy causes pre-retinal hemorrhage ataupun vitreous hemorrhage? No, cannot, because they don't have new vessels. Okay, vein occlusion, diabetic retinopathy, yes, but not hypertensive retinopathy, and that is why the reason we don't follow up those patients. Okay, now again, a lot of flame-shaped hemorrhages, tortuous vessel. You can see a bit of silver wiring as well. Blood hemorrhages here. Okay, optic disc is not swelling, looks fine. Cortical spot. Can this be hypertensive retinopathy? Yes or no? No, cannot. Because why? Because, okay, now, because this is sectoral. All right. Diabetic hypertension has to be in all 4 quadrants. So this is branch retinal vein occlusion. Now, guys, you can actually interact with us. You can actually this one. If you use this, you can say yes or no, right? Semua tahu pakai yang ni tak? In case I ask a question and ask you, okay, how many of you says yes? So what you do is you click on the participant just now, and you can actually say tick yes or no. Yeah. So that will give me an idea whether everybody understand or not. Can I have a hands up, yes or no? Can you follow now so far? Ada yang no tak? Anyone need me to repeat? Anybody is typing in the chat, you can feel free to ask any question in the chat. Nanti we go back to the question later. What about the others? What about Siti Hajar? What about Nur Shamila? What about Mohan Raj? Justin? You okay, yeah? Okay, now we will go for the next one. Let's see. Okay. Now, this is central retinal artery occlusion. Okay, why do you diagnose the CRAO? Remember, your vein occlusion has a lot of hemorrhages, but your artery occlusion does not have any hemorrhages. Yeah, it's completely pale, white, but you get a cherry red spot at the center of your retina. Why do you get cherry red spot? It's because, remember your blood supply just now, your photoreceptors, your fovea is being supplied by a choroidal layer. So when you get one of the one occlusion in the artery, retinal artery, the whole retina will be impacted, white, but your fovea will be preserved in terms of circulation, but not in terms of vision. Yeah, vision, it will be affected as well very badly because the nerve fiber layer is affected. So, but then on fundoscopy, it will appear as a cherry red spot. This is an ocular emergency. Yeah, refer the patient immediately. Ideally, if you want to save the vision, it has to be within 6 hours of the event. Anything more than that usually is difficult to salvage. Yeah. Now, read a bit about non-arthritic AION. It's not part of your hypertensive retinopathy, but it increases the risk of having AION if you have hypertension. Yeah. What happened is in this type of patient, they have optic disc swelling. I think this AION will cover in your acute vision loss. Yeah. So this type of patient, usually vision is a lot more worse. They don't have much of hemorrhages, and optic function will be abnormal. Okay. So read a bit about AIN. Now let's look at the differences. Come. Again, this is the RVO, commonly unilateral. BRVO, branch ocular vein occlusion, commonly unilateral as well, and sectoral. Yeah. Hypertensive retinopathy, nampak tak? Yeah, it's all in all quadrant, and it has to be bilateral most of the time. And then your severe MPDR is also bilateral. Severe MPDR, you see a lot of these blood hemorrhages. Okay. Now, okay, finish with your hypertensive retinopathy. Any questions so far? Where do I look for chat? Like this chat. Oh, chat. What is the chat? Prof, what did you make regarding acute rise of grade 4? Acute rise in background of normal BP or chronic hypertension? Okay, there's a question here from Chin Sung Ji. Is asking acute rise of grade 4 or with an underlying background of hypertension or normal BP or chronic hypertension? Okay. For acute rise of high blood pressure, it doesn't matter whether the patient is a pre-existing patient who has hypertension for 10 years, you know, or a newly diagnosed patient. It doesn't matter. The acute rise of high blood pressure will cause at grade 4 suddenly. So sometimes if the patient has a recent onset of hypertension, they might not have grade 1 or they might not have the severe wiring whatsoever, but it goes straight to grade 4 hypertension. Yeah, so it can be for all cases. Even patient has chronic hypertension as underlying or even without hypertension. Does that answer your question? Okay, good. All right. Now, we go for autoimmune diseases. Again, there's a lot of autoimmune diseases, but we're going to cover some of the most important ones. We go to your thyroid dysfunction and also your myasthenia gravis. Now, for thyroid eye diseases, it is mainly clinical diagnosis. Okay. In our setting in Malaysia, when you have patient with proptosis, regardless unilateral or bilateral, it has to be thyroid eye disease until proven otherwise. Yeah, so but proptosis can be caused by a lot of things. It can be caused by your thyroid eye disease. It can be caused by your muscle problem. It can be caused by your tumor. It can be optic nerve tumor. You know what kind of tumor, whatever kind of tumor at the back. It can be vascular cause. Aneurysm also can cause proptosis. But as a clinician, whenever you see a proptose eye, regardless of laterality, it has to be thyroid until proven otherwise. Okay, now it's a more common cause of acquired diplopia in adults. Usually, it will occur after within 18 months of the onset of hyperthyroidism. Usually, it happens in hyperthyroid patients, not in hypo. Usually not in hypo, but it can still happen. Usually, it is more common in Graves' disease, you know, in hyperthyroid patient. Very occasionally, when you do a thyroid function test in this patient, the thyroid function is normal or even low. Commonly, it occurs in hyperthyroid patient. Now, remember, once you have your thyroid Graves' disease, there like a quarter of patient might also have myasthenia gravis at the same time. So it is a very deadly kind of systemic condition that you have diagnosed patient early. Yeah. Now, Graves' disease, autoimmune disorder of unknown cause. What I want to highlight is the cause of the issue is the autoantibodies towards the TSH receptors. Yeah. So those are part of our investigation. So what actually happened in this thyroid patient? This is your eyeball. This is your muscle. And this is all your fatty tissue. Okay. In normal situation, your muscles are very small. This is very large. All right. This is engorged muscle. And the fatty tissue is usually is not as big as this. Yeah. But what happens in thyroid eye disease? There will be a lot of this increased secretion of glycosaminoglycan. So what happens? It will just increase the osmotic pressure in blood water into the fatty tissue and also the muscle, and it will cause the muscle and fatty tissue enlargement. Yeah. So it is very important. It's a very inflamed situation. So you have to treat patient at the inflamed state. What will happen if you ignore them? What will happen if you don't do anything? The issue is, remember, all inflammation will heal with fibrosis, right? So if you don't treat them, they will end up with fibrosis. So instead of having diplopia for a few months, but if you don't treat them, they will have diplopia lifelong, because once it has reached to fibrosis level, regardless of whatever treatment you give, it will never respond. All right, so you want to diagnose patient at the early stage of thyroid eye disease because you need to start them on anti-inflammatory medication to reduce all the swelling and avoid patient to go into fibrosis. Yeah. So remember, whenever you have a muscle, you always have a tendon. There's a special thing about this thyroid eye disease whereby the inflammation occurs in all area, but not the all the whole throughout the muscle, but not the tendon. So that is the important features that you look for when you do a CT scan on the patient. Remember, when a patient has proptosis, you have to do a CT scan because you have to rule out whether the patient has what you call tumor behind the eye. So when you do a CT scan, let's say when you do a scan, you see everything is fine, there's no tumor, and you start looking at the muscle. The moment you see the muscle is enlarged, but the tendon is normal, then you know it's most likely thyroid eye disease. We call it tendon sparing enlargement. Yeah, on the CT scan. Now, basically, this is what people describe when you see patient with thyroid eye disease. They're talking about the soft tissue involvement akan menyebabkan the periorbital swelling, conjunctival hyperemia, chemosis. Okay, I'm going to mention this one new words to you: superior limbic keratoconjunctivitis. Don't worry about this. We'll come back to the word later. Yeah, you have eyelid retraction, so everybody knows this. Proptosis. Remember, when the swelling at the back of the eye, you have your optic nerve at the back. So there's always a risk of having optic neuropathy. And eventually, restrictive myopathy. Okay? Now, normal position of eyelid. This is why it is important. Because you're going to use this to diagnose patient with thyroid eye disease. Okay, how do you see your patient, your friends? Normal eyelid in relation to the cornea. This is your eyelid, your cornea, your pupil. Okay. Upper lid should be covering at least 2 millimeters of the superior part of the cornea. Lower eyelid should be just touching the inferior cornea. So that's the normal position of the eyelid. Okay. So superiorly it covers a bit. Inferiorly it should be touching your cornea. Why is this important? Because when you want to diagnose a patient with early lid retraction, this is what you see. Nampak tak? Remember, normal eye, you have the upper lid covering. This upper lid looks normal, but the inferior eyelid should be touching the inferior cornea. So the moment you see some scleral show, this is what we call scleral show, you suspect patient might have thyroid eye disease. Okay? Now how am I going to describe this? Periorbital swelling and lid swelling, obviously, looks very puffy. There is also injection of the conjunctiva. There's also scleral show. Yeah, so these are the features of thyroid eye disease. Okay, now sometimes you get a patient who does not have much of proptosis, but you see everything is just injected. So those are also patients that might have an active thyroid eye disease. In this stage, it is an active disease. For you, when you see a patient with thyroid, what's important to you to know is whether this is active or this is non-active. All right, so this is an active thyroid. When the moment you see a red eye in thyroid patient, suspect it is an active thyroid eye disease. Okay, because it's a strong criteria for the activity of the eye. Now, again, this one you get what we call puffiness, soft tissue swelling, superior and inferior puffiness. Then you see the inferior scleral show, and this one, of course, another inferior scleral show a lot with a lot of chemosis. Chemosis means your conjunctiva is prolapsing out from its position because it's so inflamed. Yeah, so you get chemosis. Now, this is superior limbic keratoconjunctivitis. It's good to know, but I think for a level, you don't have to read so much. What happened is there will be swelling of your eyelid in the inner part of the eyelid on the tarsal, and it rubs on your cornea. Yeah, so it causes this irritation of your cornea. So superior limbic keratoconjunctivitis is one of the features for your thyroid eye disease. Okay. Now let's see what happened. What else? Now this patient, they have a very white eye, but you can see at the incision of the muscle. So remember, your rectus muscle is being inserted here. Medial rectus is here. Lateral rectus is here. Sometimes you don't get the whole eye become red. What you get is just the inflammation around the insertion of the muscle. Yeah, so that is also a sign of an active disease. Now look at this. This is what we call lid retraction. Remember, your upper lid should be covering the a bit of your upper part of your cornea, but this one is being pulled up. So there's a bit of lid retraction. As well as this one, nampak? Usually it should cover a lot more, but this one is a bit, it touches the superior part of the edge of your cornea. So this has to be thyroid eye disease until proven otherwise. Okay? Sama yang ni. So you get scleral show. Remember all these words because those are the words that you're going to use to describe your OSCE. Yeah? Superior scleral show, lid retraction, inferior scleral show, injected conjunctiva, periorbital swelling. Yeah? Those are the words that you use for thyroid eye diseases. Again, lid retraction, inferior scleral show. Yeah, this one looks very quite normal. Okay? Now, lid lag means when you ask the patient to look down, initially the patient was looking up, but then slowly they'll be looking down. The moment they look down, yeah. Can you hear me? Any problem? No? Okay. Now, lid lag means the lid is lagging behind. It's been left behind. Yeah. When you ask the patient to look up, by right, the upper lid should follow. Look up. Yeah. But then you ask the patient to look down. Tiba-tiba you nampak the upper lid is being left behind. By right, it should follow down. Right? So that's what we call a lid lag on down case. So those are the signs of lid retraction. How do you diagnose patient to have proptosis? Look from the side, look from the top, and also look from below. Yeah. But usually most of the time when it's severely proptose, you don't really have to look from the side. You can actually sort of know that patient is proptose. But those for the one that you're not sure, look from the side. Yeah. Or you can actually look from the top, comparing both sides. Now, this is an example of the CT scan. If let's say patient have proptosis, you do CT scan to rule out any orbital mass. So this is eyeball, this is the lateral rectus muscle, this is the medial rectus muscle. This is the left eye, this is the right eye. So you can see the muscles are very much swollen, yeah, and it is tapered towards your tendon. So there's actually sparing of the tendon, yeah. So this is a sign of the for CT scan. Now, one of the things that can happen for thyroid patient is when there's enlargement of muscles and also fatty tissue at the back, it might compress on your optic nerve. Yeah, so that is when patients start to complain, vision will drop. Now remember, when you talk about optic nerve, you always have to talk about the optic nerve function. What is optic nerve function test? Visual acuity. Okay, color vision. Color vision means there should not be any discrepancy in terms of red, green, especially. Yeah, patients should be able to differentiate red and green color. The moment they cannot differentiate, you think about patient having optic nerve dysfunction. RAPD, relative apparent pupillary defect, will be present, and visual field defect is also present. So those are the tests that you do to know whether the optic nerve is affected or not. Now, usually optic disc appears normal, yes, unless it's very badly swollen. Now remember one thing, if let's say the swelling at the back of the eye, you know, if all the fatty tissue here can compress the optic nerve, it can also compress the eyeball, yeah, from behind. So if it compresses the eyeball from inside, when you do fundoscopy, you see a lot of this striation, okay, because something is compressing from behind. So at this juncture, usually vision is already affected. Now this is just to show restrictive myopathy. When you ask the patient to look right and left, you know, for example, this one, you ask the patient to the right eye is moving well, but the left eye is obviously affected. Patient cannot move the left eye. Yeah. So this is adduction. Remember, okay, when the patient look inside towards the nose, you call it adduction. When the patient look outside towards the ear, you call it abduction. All right. Adding inside means ADD. Easy to remember. Outside is abduction. Anything goes inside, it calls ADD. Contoh this one. This right eye is adducting. So ADD, adduction. All right. And left eye is abducting. All right. So what you look for in both eyes, it should move symmetrically. If it doesn't move symmetrically, suspect some restriction. Okay. Now, how can the patient end up with complication? Now, the eyelid should be covering the cornea all the time. Yeah, when you blink, it should cover the cornea. Can you imagine when a patient is proptosed, the cornea is not being covered properly. So what happens is they have a lot of the cornea can be very dry, and it can cause ulceration. It's like when you have an ulcer on your mouth, but you have an ulcer on your cornea. Yeah, so the same thing can happen. Now, this is an example. Okay, cornea should be very clear and it should be moist all the time. But when you get a proptosis in which the upper lid or the lower lid could not cover the cornea nicely, you will get some erosion. Yeah, the moment you get erosion, because it's very dry, then slowly you will get the ulceration. This is an ulcer. Okay, so those are the ocular complication of thyroid eye disease. How does a thyroid can cause blind? Number one, it can affect optic nerve. Number two, because it compresses on the eye, it can cause high intraocular pressure. Yeah. And number three, it causes exposure keratitis. Exposure keratitis just means a ulcer, summer, same meaning. Yeah. Okay. Now, blood investigation are mainly systemic blood investigation. Either your thyroid function test and also your CT scan or MRI. How do we treat the patient? If patient in active condition, you have to give them metaprednisone. Depends on the severity of the eye condition. If the optic nerve is affected, you have to give intravenous metapred. If let's say there's a thyroid eye disease, but the vision is still perfectly good, you can still give them oral prednisolone. Okay. Now, sometimes they don't respond to prednisolone. You might have to give them the second line agent, azathioprine or the cyclosporine. Sometimes, again, still, patient do not respond to all this medication, then you end up giving them radiotherapy to the eye. Eventually, if let's say diplopia does not resolve, you might have to go for surgical decompression. Surgical decompression maksudnya apa? Your eyeball, there's a wall around your eye, kan? You have your superior wall. Sorry, you have the one goes to the one on top is your superior roof. Okay, that one is another anatomy. But at least you have to remember that the eyeball is being surrounded by bones. Okay, so decompression means they will break one of the bones to give space for the enlarged muscles. Yeah, usually they will break the inferior bone. Yeah, to treat the patient. So eventually they give screen surgery. Okay, habis thyroid. Those are the important things about thyroid. Any questions in the chat so far? How do I look for the chat? Chat tak ada. Okay. Okay, now let's go to myasthenia gravis. Myasthenia gravis, again, an autoimmune disease. There is actually a reduction of the acetylcholine receptors on the end plate, right? So it reduces the response at the neuromuscular junction of the skeletal muscle. Remember, it's a skeletal muscle. Your extraocular muscle is also a skeletal muscle. Yeah, so that will be affected as well. Now, again, because it's a systemic disease, usually it will cause bilateral ptosis. Extraocular movement will be affected. Patient will complain diplopia, but usually because it has some association with fatigability, which means in the morning, patient is fine, but towards night, they start to feel they have double vision. Yeah, diplopia means double vision. So when you start to have that kind of symptoms in a patient, you suspect patient has a myasthenia gravis. What easy test you can do to the patient? If you get a patient with ptosis or myasthenia gravis, you put an ice pack for 2 minutes. Yeah, get an ice pack, put for 2 minutes. After 2 minutes, you get the patient is able to open the eye. So most every patient has myasthenia gravis. This is not pathognomonic, but it's just a bedside test that you can do. Apart from that, you can also do your tensilon test, your antibody towards your acetylcholine receptors. We can do the RNS, the repetitive nerve stimulation test, single fiber EMG, or even a CT scan. Now in EMG, remember they might have they have this what we call thymus gland enlargement. So when you do CT scan, you look for the thymus gland enlargement, yeah, behind the mediastinum. Treatment-wise, we give them pyridostigmine, neostigmine. We do give them, because it's autoimmune disease, we just give them the prednisolone as well, yeah, or the cyclosporine. Sometimes it's very bad, you might give them plasmapheresis. And surgical-wise, if there's a enlargement, we will do a thymectomy, yeah. So nothing much, not so detailed, but that should be enough for your level. So remember, kalau thyroid eye disease, you get lid retraction. For myasthenia gravis, you get ptosis. Yeah. Now, still okay? Dah ada yang tertidur? Tak ada? I can't see your reaction apart from Evelyn and also Ahmad Hatim je nampak. Azim pun ada. Okay. And then I tak nampak reaction. Kalau ada tertidur, I'm so sorry. Wake up, wake up. Okay. Boleh continue. Sikit lagi. I have 30 more slides to go. Yeah, can. Good. Okay. Now let's go for connective tissue disease. Now, remember your eyeball just now when it comes to anatomy, you have the eyeball, the coating of the eye, which is the cornea and the collagen is made up of, the cornea and the sclera is made up of collagen, avascular, yeah? The retina and the choroid is vascularized. So when it comes to rheumatoid arthritis, it will not affect your retina or your choroid whatsoever, it will affect your cornea and your sclera because it's a collagen kind of, it affects your connective tissue, all right? So you don't get retinitis whatsoever in rheumatoid arthritis. Okay, what you get is when it affects your cornea, you get a dry eyes. We call it keratoconjunctivitis sicca. Sicca means dry, Kerato means cornea, conjunctivitis, all right? You get dry eyes. Again, if the cornea is so dry, you get a melting. That's what we don't want to happen. Yeah, the cornea itself, the thickness is very, very thin, 500 micrometer. On top of that, you get melting of the cornea. Now, episcleritis means it's on top of the sclera, so you get injected episclera area. Scleritis again is a whitish coating of the eye, so you get inflammation everywhere. The cornea is inflamed, or even your sclera is also inflamed. So this is the patient's eye. This is what can happen, particularly for a rheumatoid patient. They can have melting, not only on the cornea, but also on the sclera. So when they get melting on the sclera, what is this? This is your choroid. Sebab the lapisan sclera tu dah melt. Alright, so that is when you don't want this to happen, because eventually it will perforate. So we don't want that to happen. Yeah. So rheumatoid arthritis can get thinning on the cornea and also thinning on the sclera. Okay. For another example, the eyes are red. How gonna explain this on your OSCE question? Injected eye. What else? You get this area is whitish area. Remember, your cornea should be very clear. The moment you get white patch with a red eye, think about ulcer. Okay, you get a white patch on the cornea plus mata di merah, think about ulcer. So this is ulcerative keratitis. You call it peripheral. This is what can happen to them. So they ulcerate, eventually they melt. So this one is actually a gutter. It's like longkang dah dekat sini, yeah, because it's actually melting. So this also can happen to the patient with rheumatoid arthritis. Habis, dah cukup, itu sahaja. Treatment wise, again, because it's autoimmune disease, going back to the systemic treatment, which is your steroid as the first line, and also your second line if it doesn't respond. Yeah, but usually patient like this, they have some active rheumatoid joint elsewhere. Yeah, so usually also this kind of patient, we don't follow them up. What we do is we see them if they start to complain. Right? Now, let's go to multiple sclerosis. It's a chronic relapsing and remitting, sekejap ada, sekejap tak ada, of the central nervous system. Where is the inflammation? Inflammation is at the myelin sheath of the axon. So let's see this. What happened is much more common in female. Peak age is quite young, 30 years old. Okay. If the patient comes with other symptoms of multiple sclerosis, remember your medical posting, they can have limb weakness, which occurs in 40% of patients. But have to remember that 60% of them, majority, do not have any weakness of the limb. They come only with optic neuritis. Okay, so that could be one of the first signs for them to tell that they are actually having underlying multiple sclerosis. So what happens is they will present with acute visual loss, some paresthesia. They might complain a bit of diplopia, depends on the location of the disease, and some of distribution of material. This again depends on the location of the disease. But let's concentrate on optic neuritis this time. Now, going back to your optic nerve function, please remember all the 5 optic nerve function tests. Yeah, the visual acuity, RAPD, visual field, and also color vision test, and also light brightness. Okay. Yang ni RAPD all belajar dekat acute vision loss kan? I will not go into that into deep RAPD. Yeah. Okay, now let's see, how does an optic neuritis patient presented? Usually it's unilateral. Patient will come, let's say a 20 or 30-year-old female come with reduced poor vision. You check the vision is probably about 660, very bad. RAPD is positive in affected eye. When you do visual field defect, you get a central scotoma. Central scotoma means they can see everything at the periphery, but not at the center. They can see the whole room, but they cannot see your face. Yeah, if you are actually the treating doctor, they will tell, I cannot see your face, doctor. I can see everything at the side, but not your face. Yeah, ataupun they say, I can see your eyes, but not your nose. So that is central scotoma. Yeah. They have a color vision. How do you test color vision? Usually we just give them, if you have anything like a red cap bottle or your red pen, the cap of the red pen, just compare right eye and left eye. They will say the color of the affected eye is not anymore red. Yeah, it might be a bit greenish. The hue will be different. So that is what we call a color defect. Optic disc. Okay, when you do fundoscopy, you will see an optic disc swelling. Optic disc swelling usually comes with hyperemia. That means the color will be more red, hyperemic, and swollen. Sometimes you might have a bit of hemorrhages, but usually optic disc swelling per se is enough for you to diagnose optic neuritis. Now, there's a special thing about this optic neuritis. If the patient comes to you with all the optic nerve dysfunction and you suspect the patient have optic neuritis, so what do? You will do a fundoscopy. So when you do fundoscopy, if you see this optic disc swelling, then you know the diagnosis will be optic neuritis. Okay, so you start all the treatment and start to investigate the patient. But what if when you do fundoscopy, everything looks perfectly normal? So, but yet the optic nerve function is there. Sorry, optic nerve dysfunction is there. Yeah, but you do a fundoscopy, everything looks perfectly okay. Suspect this patient have retrobulbar optic neuritis. Okay, provided the patient is young, unilateral. That points towards retrobulbar optic neuritis. That means retrobulbar means behind the eyeball. Bulbar is the eyeball. Retrobulbar means behind the eyeball. So probably optic nerve yang inflamed, which is not in the eye itself, but the one behind the eye. Now, this is a Jerem test. Unfortunately, this is during MCO. You cannot go and visit the patient, our room. So this is how we do a visual field test. This one is not testing the whole lot of your visual field. This is just to test at least about 30 degrees of your visual field. Yeah. So this is actually, okay, this is how you read it. This is your left eye, this is your right eye. So for the left eye, you can see this. This is a normal blind spot. This blind spot occurs because of presence of optic nerve, right? When there's an optic nerve, everybody will have a blind spot. If you test yourself, semua kena ada blind spot, yeah? But the size is quite small. And compared to the other side, probably patient cannot see the target, and at the same time they have a central scotoma. So the finding of this patient is right eye central scotoma. Yeah. Now, this is how we do a color vision test for the patient. For color vision, we will give them 15 sets of color and get them to arrange the color according to the hue. So dia akan turun from color biru, turun jadi hijau, jadi merah, you know, the hue of colors to arrange. But then in the left eye, this is how a normal color vision looks like. Looks like a C shape like that. But then for the abnormal eye, they will not see anything. Yeah, they cannot arrange those colors. Yeah. Now, this is, if you do fundoscopy, you can see the optic disc is swollen. Margin is poor. You can see the cup-disc ratio, but you can't see, right? The other eye is also having the same thing. Sometimes you can get patient who has bilateral optic neuritis. Yeah, but usually it doesn't come concurrently. Usually probably 2 weeks ago it started with this eye, another 2 weeks it comes with the other eye. Yeah, so you might still have patient with bilateral optic neuritis, but commonly is unilateral. Principle of treatment, patient, we give them steroid. All the symptomatic treatment depends on the location of the lesion. And sometimes we give them disease-modifying agents. So all these patients with optic neuritis, we really have to do MRI because we need to know whether the patient have idiopathic optic neuritis or they have multiple sclerosis. Yeah. So if you have multiple sclerosis, then all this treatment is necessary. There are some patients who doesn't have multiple sclerosis. All they have is just optic neuritis sahaja. Usually it's post-viral. That is only usually one attack. Yeah, those type of patients, they will not get all this kind of treatment. Okay, when you do MRI, they are completely fine. Okay, habis banyak actually for your systemic diseases ni. Okay, we cover a bit on the AIDS for HIV-related eye problem. Now, this is a long list what HIV patient can have in the eye. Yeah, Kaposi sarcoma, molluscum, all these things I think tak payah baca lah kot banyak sangat for you guys. What you have to know is this: HIV retinopathy, yeah, syphilis, all these opportunistic infection when your system is down. Toxoplasmosis. And another one is your CMV retinitis. So those are actually infective causes that you have to know that can cause blind for the patient. Yeah, yang lain-lain tu I think for level tak perlu sangat. Yeah, so this is more important than the rest. Let us concentrate on the CMV retinitis, cytomegalovirus retinitis. Potentially it's blinding condition. Selalunya it will occur to those with a very low CD4 count. Okay, the CD4 count has to be very low usually. Patient can be very asymptomatic, no complaint at all, but they have a lot of retinitis. Why they don't have any complaint? Because the fovea is not yet affected usually at the beginning. Towards the end, then only they will complain. Yeah. If they have any complaint, they might complain of floaters or painless loss of central or peripheral vision. At least 20% to 40% of HIV patient might diagnose with CMV retinitis at some point. Now, how do we diagnose that? If you do a fundoscopy, what CMV retinitis? Remember, it's retinitis, so it doesn't affect your optic nerve. It doesn't affect your choroid, but it affects your retina. Retinitis. Okay, it will appear like your pizza slice, a triangle-looking pizza slice with a bit of pepperoni and ketchup whatsoever. It's quite typical. The moment you see a whitish lesion with a bit of, there's ketchup there, hemorrhages here in a triangle pattern, most likely it is CMV retinitis. Yeah. Now again, this one is quite extensive. So you get this white patch area is an area of retinitis, and this is some hemorrhages. So you get hemorrhagic retinitis. So this is also in CMV patient. If you get a patient with HIV, the first thing, if the patient complain, is to rule out CMV retinitis because it can be very aggressive. How do we treat them? Kita akan bagi dia intravenous ganciclovir or any other antiviral, depends on their response. And we also have intravitreal. Intravitreal means we inject the ganciclovir inside the eye itself. Yeah. Patient has to be on a specific regime of treatment for the first 2 weeks, and after that you still keep injecting them a couple of weeks after that. Yeah, so treatment-wise take a longer duration. Now, sometimes if the patient has a bit of money, then we can actually, because there's another oral preparation for ganciclovir, which is a vial ganciclovir. Good penetration into the eye. It's just the issue is a bit more expensive. Yeah, this can also be used in the acute treatment of the CMV retinitis. Now, toxoplasma retinitis. Where you get your toxoplasma? You get your toxo from your cats. So, siapa the cat stocks so careful? Yeah. I think Malaysian, a lot of us have positive IgG towards toxo. But because we have a good immune system, we don't get all the attack or the relapsing of those toxoplasma. But in HIV patient, you get a lot of this toxoplasma retinitis. You don't see that typical hemorrhagic ketchup, macam the CMV, kan? All you see is this white patch. So this is usually in patient with toxoplasmic retinitis. Okay, cukup. Dapat diagnose pun cukup. Ya, for your level. Tak payah tahu too detail. Treatment-wise depends on the causative agent. Kalau infection tu caused by syphilis, caused by toxoplasma, it goes back sama macam systemic treatment. Yeah. Now, I will touch a bit about uveitis. Okay. At least when you read uveitis tu taklah, because this is very quite detail. No, uveitis is quite how to say, it can be quite complex. But at least for your level, you should know at least anterior uveitis and also posterior uveitis. Okay. Okay. What is uveitis? Uveitis is inflammation of the uveal tissue. So where is your uveal tissue? Uveal tissue is your iris, ciliary body, choroid. The second layer of the coating tu semua tu uveal tissue. Alright. So inflammation of the uveal tissue will cause uveitis. Okay, yeah. So whether it's anterior or posterior depends on the location. So kalau let's say the inflammation occurs on the iris, because you have to remember everything is actually connected from front to the back. Yeah. Color inflammation occurs at the iris level, then you call anterior uveitis. If it occurs here, we call it intermediate uveitis. If it occurs at the back, we call it posterior uveitis. If it occurs from anterior to the back, we call it panuveitis. Okay, but for your level, at least if you know a bit about anterior uveitis and posterior uveitis pun dah cukup. Yeah, intermediate tu semua tak perlu sangat. Yeah, you don't need to do that. Okay, let's go through some pictures. Now, why is it important for you to know about uveitis? Because it can be caused by the common organism in Malaysia, tuberculosis. Okay, patient can have, biasanya usually it's indolent type, not when the first patient have a contact with tuberculosis. Yeah, patient can be asymptomatic in terms of coughing whatsoever, but patient end up with this tuberculosis in the eye. Yeah, it's autoimmune kind of disease towards the. It has some kind of autoimmune as well because it reacts towards your the indolent kind of TB. Now, we have sarcoidosis. Sarcoidosis can also cause uveitis, and we also have the HLA-B27. Now, I try to summarize here what are the causes of other uveitis. PJAR. Psoriasis can also cause uveitis. Yeah. Your Crohn's disease, the inflammatory bowel disease can also cause uveitis, juvenile RA, ankylosing, and also Reiter syndrome. So those are the common ones that causes uveitis in patients. Okay, how do they present? Okay, remember those terms. These are all the terms, ciliary injection. We come to the photo later. Yeah, we have anterior chamber cells, we have granulomas, we have synechiae. Look at the synechiae, fibrin, and hypopyon. Okay, don't worry about all these terms. We go to the pictures. Now, let's see. Oh, ada a bit of overlapping. Sorry about that. Probably should animate this so that dia tak kacau. Tak boleh lah. How do I do that? Sorry, let me just cut this off so dia tak kacau your. Cut this. Okay, I paste it later. Okay, let's see this first picture. Okay, this is your cornea. Okay, what is the abnormality you can see? Pupil is dilated. This is a not normal size pupil. Can you see this white thing here? This is what we call keratic precipitate. Keratic precipitate is mainly the sedimentation of white cell. Yeah, in this type of patient, they have inflammation of the iris tissue. So you call it anterior uveitis. When you have anterior uveitis, inflammation, that means white cells are leaking out from the vessel, betul? So the white cells will be accumulating on the cornea. So when you do a slit lamp, when you look from the front, you can see all this precipitation of the white cells. Now, some patients might not have the KPs. What they presented with is the posterior synechiae. The synechiae is just mainly tells you there is an attachment. What is attached? Okay, this is your pupil. In normal condition, pupil is sitting in front of the lens. Yeah, it's next to each other, but it's not supposed to be touching each other. All right. In synechiae, there will be some scarring in which the iris will be plugging onto your lens. Okay, so that is what we call posterior synechiae. Okay, let's say this is before dilatation. When you put the dilating drop, let's say you need to look at the fundus, kata, let's put a dilating drop. So once you put the dilating drop, some part will be dilated, but some part will still be attached. Nampak tak ada scar tissue there? Yeah, so you get like a flower shaped kind of pupil. Suspect patient has anterior uveitis. That means the pupil cannot be fully round shaped like that because ada some scarring or synechiae. Okay, if the iris attached to your lens, we call it posterior synechiae. If the iris attached to your cornea, you call it anterior synechiae. Okay, now sometimes the white cells is this one, the white cell is sitting on the cornea. This one, the white cell is sitting on the iris. Then you call it iris nodule. It's actually basically the same thing. It's just inflammation of a white cell. Kan? Cuma it depends on where the white cell resides. If it is on the cornea, you see KPs. If it is on the iris, you see iris nodules. Okay? Sometimes you just get the reaction, the fibrin. So everything is just fibrin. It's like cobweb. So those are the signs of anterior uveitis. Now let me paste back my, there you go. So another way, another presentation is when the patient have what we call hypopyon. Hypopyon level is a white cell sediment inferiorly, not on the cornea, not on the iris tissue, but at the angle inferiorly, you get hypopyon. So all this is actually pus. So the moment you see this kind of situation, suspect patient has anterior uveitis. There's another condition for you to see, to diagnose if the patient has hypopyon. Apa dia? Post-cataract surgery, hypopyon, you suspect endophthalmitis, right? Infection in the eye. But for this type of patient, usually they don't have any surgery, nothing, but yet they have hypopyon. So these are anterior uveitis. Causative factor is your tuberculosis number 1. Yeah, the rest is your autoimmune diseases. Okay, posterior uveitis is at the posterior. So when you see the patient, the cornea looks clear, the pupil looks clear, there's no posterior synechiae, but when you do fundoscopy, you see retinitis. Okay, so your toxoplasmosis is also a posterior uveitis. Kan? Toxoplasma pun ada retinitis, right? So that is posterior uveitis. What else? Your CMV retinitis is also a posterior uveitis. Anything location at the back, inflamed at the back, you call it posterior uveitis. Okay. Now you have retinitis with a bit of vasculitis. Then you have, this is a blood vessel. This is again white cell sediment along the blood vessel. Okay. And vitritis means there's a lot of cells in the vitreous, so you cannot see the optic disc clearly. Okay, so these are the posterior uveitis. Just now was anterior uveitis. Okay, how do we treat them? Again, go back to the causative factor. Remember the causative factor for uveitis just now ada banyak, but the top one you should think of tuberculosis. So we do all the mental tests, we do the chest X-ray to rule out TB or sarcoidosis, we do the ESR, and also to look for any systemic association, ankylosing spondylitis or your ACE level for your sarcoidosis. Yeah, so look for the underlying cause of the uveitis. If it's TB, you give anti-TB treatment. If it's just anti-uveitis without any causative factor, then you might want to give them just steroid. There are some conditions whereby you do all the investigation, nothing comes back as positive. Yeah, so those kind of patients, you just give them topical steroid. Posterior uveitis, you give them steroid as well, except if the patient has tuberculosis or infective causes. Yeah. Okay, boleh faham tak? We're coming to the end of the slide. I think this is that. That's it. Thank you. Any questions so far? Alan. It's either you understand everything or you don't understand everything. Okay, let's go to your participant punya ni. Let's see how many of you says you don't understand this lecture. Mana dia? Where does it go? Cepat click on the participant. Meanwhile, in the chat, feel free to ask any question if anybody has any question. Okay, I give you the rate from 1 to 10 because this is the first time I work online. Can you give me a rating? 1 tak faham, 10 faham. So, semua orang tulis right dekat you punya chat, boleh? So that will tell me sama ada my online teaching is doing well or not. 1 tak faham, 10 faham. So letak kat mana? What number? So that will give us a guide. Oi, 10 ya tu. Okay, any questions so far? I know there's a lot of these new terms in ophthalm. Yeah. Feel free to ask questions. So those who understand, that's good. But those who don't understand, feel free to ask any question. Anybody wants to ask me any question also can freely email me, drmusha@gmail.com. Semua online kan sekarang? We can meet you. In case you have any question pertaining for this lecture, feel free to email me at drmusha@gmail.com. Yeah? Okay, good. So most need further reading, Prof. Alamak, Sia Hidayah. Tak faham lah tu. Never mind. I know there's a lot, but remember in your, I don't think you need to use to read too much. Use your lecture as a guide, because kalau you tengok buku Opta, there's a lot. There's a lot to read, but make sure you concentrate the common things. Yeah. No, you don't have to read every single pages. Just remember one thing: the eye doesn't know. What is it? The eye doesn't see what the mind doesn't know. Maksudnya, if you don't know the disease, you don't know how it looks like, the disease can be just staring at you, but you don't know what it is. So in Optal, the best way to learn is look for a lot of images. Buka Google image. Kalau you baca hypertensive retinopathy, buka all the images for hypertensive retinopathy. When you baca diabetic, you Google the images. What you need to do in Opta is just to look at images. Itu je. Kan? Because when you go for your final exam, what you need to do is your short cases, kan? So for you guys, your level should be diabetic retinopathy, glaucoma, what else? ARMD. That one I didn't touch in my lecture, but make sure you guys read about it. Age-related macular degeneration. Yang tu kena tahu. Yeah. So concentrate on the important ones.